Patients with heart failure and left ventricular dilatation may have secondary or functional mitral regurgitation. This is due to alteration of the left ventricular geometry, producing changes in the functioning of papillary muscles and chordae tendineae, and poor coaptation of the mitral leaflets. Secondary mitral regurgitation causes volume overloading of the left ventricle and is associated with reduced survival, increased hospitalization rates, and decreased quality of life. Secondary mitral regurgitation can be reduced by guideline directed medical therapy and cardiac resynchronization therapy. This will also provide symptomatic relief and improve left ventricular function. Everest II trial comparing percutaneous mitral valve repair and surgery for mitral regurgitation had concluded that percutaneous repair was less effective at reducing mitral regurgitation than conventional surgery. But percutaneous repair was associated with superior safety and similar improvements in clinical outcome. An exploratory subgroup analysis of Everest II trial showed that surgery was not superior to percutaneous treatment in functional mitral regurgitation. This observation was the reason for initiating the COAPT trial of transcatheter mitral valve repair in patients with heart failure. The COAPT trial was conducted at 78 sites across United States and Canada and enrolled patients with heart failure having moderate to severe or severe secondary mitral regurgitation who were symptomatic despite maximal tolerated doses of guideline-directed medical therapy. They were randomly assigned to either transcatheter mitral valve repair plus GDMT or GDMT alone. Primary effectiveness endpoint was hospitalization for heart failure within 2 years of follow-up. Primary safety endpoint was freedom from device-related complications at 1 year. Freedom from device-related complications at 1 year was 96.6%. Analyzed rate of hospitalization for heart failure within 2 years was 35.8% per patient year in the device group and 67.9% per patient year in the control group. All-cause mortality was 29.1% in the device group and 46.1% in the control group. Similar benefit was noted in those who had ischemic and non-ischemic cardiomyopathy. Same was true of those at high risk for surgery versus those not at high risk for surgery. Benefits were found to be independent of the grade of mitral regurgitation, left ventricular volume, and function at baseline. Device-treated patients also had better quality of life and functional capacity at 2 years compared to those on GDMT alone. Improvements were attributed to the decrease in severity of secondary mitral regurgitation by transcatheter mitral leaflet approximation by the device. Decrease in hospitalization for heart failure was noted within a month of device therapy, while mortality benefits occurred more than a year after treatment. Procedural success was noted in 98% of cases, with a decrease in mitral regurgitation grade of 2+ in 95%. A potential bias in the study was that the device would be visible on imaging at follow-up so that it would make the assessment not a truly blinded one. But that would not affect the hospitalization rate and mortality rate, which showed improvement in the trial.